Please, first of all, thank you so much for coming. Love the energy in the room. I know there's a lot of enthusiasm in the building this week. We're really blessed. I hope you appreciate how lucky you are that we have Dr. Diaz and some of the things he's brought. This is a unique, this is something you don't get in high school usually, you don't get in college. This is like a grad school, med school kind of experience to have access to someone of his caliber and expertise and an actual brain in front of you. I'm going to remind you a few things. Please take a moment, make sure phones are off so they're not buzzing and beeping and ringing during his presentation. We talked about the fainting phenomenon, and be mindful of if you're feeling a little warm or a little lightheaded, get low and hunker down. Yeah, don't try to walk to the nurse. You probably won't make it. So we talked about that. We are very lucky to have Dr. Diaz here. He's been a neurosurgeon at the Med Center for I'm not sure how long. How long?
22 years.
20, and the last 10 years he's been telling me he's soon to retire, and like the mafia, it seems like he keeps pulling you back. It's a hard thing to walk away from, but we are very blessed to have him here. Please give him a warm welcome, Dr. Diaz.
Thank you. And I don't know, this is maybe the 6th or 7th time I've done this, something like that. And it's a real joy to come and talk, and the enthusiasm from the students here is really contagious. And that's why I keep coming back, because it's a lot of fun to share this with you. How many people are interested in a career in some neuroscience capacity, either a science researcher, a neurologist, neurosurgeon? I got a few. Okay, excellent, excellent. Well, hopefully I'll get a few more of you to embrace neuroscience maybe as a career. So I'm going to go through, the first part is just kind of a quick show and tell, and a sort of quick review of the stuff that many of you are studying in Mr. Steelman's class in psychology. The guy at the upper left here is a guy by the name of Harvey Cushing, who is the father of neurosurgery, American neurosurgery, and also a really prolific illustrationist. And that is his own artwork. This is a self-portrait of him simulating a craniotomy, or an operation to remove a part of the skull to access the brain for surgery. He didn't actually undergo a craniotomy. So we start with the just basic anatomy to bring us all up to speed, because we're going to see a brain in the second part of this. And so you want to be able to kind of have some idea of how it's organized. So we have the cerebral cortex, which is the lumpy, bumpy part on the top. And the red part is the frontal lobe, the yellow, the parietal lobe, the purple, the temporal lobe, and I guess that's a light blue, the occipital lobe. And then what you don't see, you see just a little bit of it at the very bottom, so-called brainstem. We'll see that much better when we cut the brain, and how the cerebral hemispheres, which are covered by this cortex, the cerebral cortex, anatomically connects to the brainstem. And then the cerebellum is connected to the brainstem as well, and we'll actually cut off the cerebellum. You'll see what are called the cerebellar peduncles, which are big sort of tree trunk kind of connections between the cerebellum and the brainstem, which then, of course, the brainstem is the highway that connects the hemispheres, the cortex, the cerebrum, to the spinal cord, which we don't have here. And then within each of those lobes of the brain, of course, we have gyri, which are the lumps, the things that stick up, and sulci, which are the little cracks between them, or little fissures between them. And they're really nicely organized. If you look at the frontal lobe here, you can sort of imagine there are three gyri, the superior, the middle, and the inferior frontal gyri. And then right here, as they come to here to the end here, there's a big sulcus there, and then this is the precentral gyrus here, this red one that's going up and down. That's where the motor strip is, if those of you have heard of the motor strip. That's the part of the brain that controls all the motor movements on the opposite side of the body. The parietal lobe has a couple of gyri, which I really won't get into. The temporal lobe, like the frontal lobe, is similarly organized. There's a superior, a middle, and an inferior temporal gyri. The occipital lobe, of course, has what's called the calcarine cortex, which is the visual part of the brain. Let me just move on here. There we go. So again, that red strip there is the motor cortex, and it's organized in a funny way in that the face and the mouth are located sort of out here near the bottom of that strip, and the hand is up more toward the top, and the feet and the legs are sort of dangling in between, in the space between the two halves of the brain. So there's a lot of localization. That's a theme that we'll talk about here. There's a lot of localization. Different parts of the body are represented in different parts of the brain, and there's sort of a map of the body within the brain. You also notice that some things like the face and the mouth and the tongue and the hand especially are bigger, and the legs and the feet are smaller, and that represents the amount of the brain that's devoted to moving that part of the body. So, you know, we have a lot of different things that we can do with our fingers and our hands, right? It's very, very precise. Precise. We have a lot of movements, so it gets a lot of it devotes a lot of area of the brain to moving all those things. You know, extending the knee really does. It's kind of gross. I mean, not gross in a disgusting sense, but gross in terms of just one movement, right? Just kind of kicking your knee out. So it doesn't take a lot of energy from the brain or a large part of the brain to make it do that. The mouth and the face, obviously, also we have a lot of facial expressions, and we move our mouths and so on. So that takes up a lot of space in the brain as well. Again, this is the sensory strip. It's right behind the motor strip. And again, you can see the face and the lips. The lips are really big on that because we have a lot of sensation in our lips, probably why people kiss. And then the hand gets a fair amount of sensory. Again, the legs and the feet, not so much. And if we look at an MRI scan, we can actually make out these things. We can see here the superior frontal gyrus, the middle frontal gyrus, and then as they come back, they tee into this precentral sulcus here, the motor strip, and then back here is the sensory strip. So you can see that you can identify these things on imaging studies like CAT scans and MRI scans. And that's just the blue circle showing the motor and sensory cortex. We also want to make sure that we talk about the inside. You know, if you take if you just take the brain and cut it right down the middle, which we'll do in a minute, you can again see the frontal lobe, the parietal lobe. There are different colors now, but the occipital lobe and the temporal lobe here, which is more around the outside of the brain, it's kind of basically right in front of your ears. And you see a couple of other structures that you may have heard about. One is what's called the corpus callosum. Anybody know what that's this thing here, this sort of C-shaped structure? Anybody know what the corpus callosum does, those of you who are in psychology?
Connects the two hemispheres.
Exactly. And what happens when you cut the two in half?
Well, then they're separate.
Yeah, which is really interesting. And a lot of times you don't really understand, or you can't tell that the two brains have been disconnected, two halves of the brain have been disconnected, which we sometimes do to control epilepsy. But if you do that and you take the patient and you have them look at images of two things, images of two things. You say, and you divide them so that their eyes can't see the two things together. And if you do, if a normal person, you'd put fire or fire truck, and they would say fire truck, right? Somebody with a split brain would basically only say truck because their left side of the brain, which controls language, sees the right side of space, so it only sees the truck. So weird things that can happen when you do that. And there's the corresponding sagittal MRI image. This is what we see when we get MRI scans. You can see how amazingly accurate it is when you compare it to that. By the way, the pituitary gland, those of you may have heard, down here is a little tiny structure. That's how big it is, really tiny compared to the brain. And it has a stalk that connects it to the hypothalamus, which is the part of the brain that controls, among other things, controls the release of hormones from the pituitary gland. interestingly, we get referrals sometimes of patients who had a little bit enlarged. I'm a pediatric neurosurgeon, so these are teenagers, and I would get referred patients because their pituitary gland was too big and they thought they had a tumor. And I would look at it and it wasn't a tumor, it's just an enlarged pituitary gland because they're teenagers. When you go into puberty, your pituitary gland actually gets physically bigger because it's churning out hormones, which is why teenagers act the way they do. But that didn't go over well. Okay, so just remember too that there are arteries that supply the brain, and there's a whole bunch of them, and they're named and so on. And there are veins that drain the blood from the brain back to the heart. And then we can think of the brain in terms of cross-sectional anatomy. If we take, and we're going to cut this brain in different planes. So we'll cut some of it this way, and some of it this way, and some of it this way. And when we're learning neurosurgery, when we're learning neurobiology, we look at these in cross-sectional images and identify all those different structures. And they all have names, which in the interest of time and boredom, I'm not going to go through those. But we can, on an MRI scan, we can do the same thing as we would in a cadaver. We can get an MRI in what's called the axial plane this way. The coronal plane is the middle one, cutting it this way from front to back. And the sagittal plane, which is cutting it through from side to side, from left to right. And depending on which one that we're looking at, we will see the same structures in different orientations and different shapes too, because they're not they're running through the brain, and so we create different shapes depending on how we slice them. This is the brain stem, so-called the superhighway, and this sits inside those two hemispheres, and we'll see that on the brain. And you can see the brain stem is divided into parts. The thalamus, which is sort of the relay station for all information coming to the brain. Sight, sound, touch, all that goes through the thalamus and then goes from the spinal cord, goes up to the thalamus and then onto the different parts of the cortex in the hemispheres. The midbrain is a little part just south of the thalamus, as it were. The pons. Sorry? What was that?
Ignore it. We'll talk later.
Oh, okay. So midbrain there. Pons, and then the medulla oblongata. I'm sure many of you have heard that term. I know every time I give this talk, the students all know about the medulla, which is sort of the housekeeping part of the brain and runs things like breathing and heart rate and so on and so forth. And again, we can look at cross-sectional anatomy of the brainstem. These are typical pictures that in medical school we look at, and again, I'm not going to go into great detail, but there's a lot of stuff crammed in. This is a picture of the midbrain, cut through the midbrain, and there are all kinds of different nuclei, little collections of cells that serve different functions. So, for example, this one I put the little blue circle around or oval around. Those are the fibers. That's the area that allows us to feel on the face on the same side. This is called the trigeminal nucleus. So lots of different, very compact areas. So if you can imagine if you damage the hemispheres, which are quite large, you can damage parts and not have a whole lot of damage, not see a lot of damage in terms of the patient. For example, I can take out large parts of the frontal or anterior temporal lobes, and the patient actually won't miss them at all. They won't be any different when they look up. In contrast, if I take just a tiny little bit of brain out of the midbrain or the pons of the medulla, that'll have devastating consequences. Here is this one little area here, the hypoglossal nucleus, which is in the medulla, a little circle right there. Damage to that produces paralysis of the side of the tongue, and that side of the tongue shrivels up. We call that atrophy. And so it kind of just gets wrinkled and smaller. And when the patient tries to stick out their tongue deviates to that side because each side pushes the tongue out. So if this side's paralyzed, this side will push the tongue in that direction. So when we examine the patient, we are looking for evidence of damage to different parts of the brain, which are manifest in our physical examination. And then the surgeon has to do all of that we just talked about, and now has to put it all together and visualize surgically what things are going to look like. And when we operate, it's not just, we don't operate strictly like this, sagittal, coronal, axial. We're coming in at sort of an angle, and so things are going to look even stranger. There's a lot of surface anatomy that we have to be very familiar with when we're operating to identify all of these different things. So a lot of different perspectives for us. And we have to put that all together, that knowledge, when we're operating on somebody. And we have to know where we are at any one time. So this is a child with a tumor involving the cerebellum. So this is a sagittal MRI scan done like this. Here's the cerebellum. And you can see this sort of whitish area here is a tumor in the cerebellum. Here's the brain stem, the midbrain, the pons, and the pons has some tumor within it, and the medulla as well. And here's the spinal cord down there. We also have to take into account distortion of the structures, basically because of pathology. So if we have a tumor, the structures around it may be either infiltrated, they may be invaded by the tumor, or they may be pushed to a different location by the tumor pushing on it and pushing it to the side. So we have to not only know where it should be normally, we have to take into account the possibility that it's not going to look the same when we put a tumor or some other thing in there. Not we put it, but when God puts it in there. Go back. So here is the optic chiasm here, you can see right there, and the optic nerves coming in, it sort of forms an X like that, and the optic tract coming right here. And that's what it looks like normally if you look at it from the bottom. Here's what it looks like on an MRI scan, nicely seen, the optic chiasm here, and the two optic nerves coming in, one from each of the two eyeballs up there. Here's what it looks like at surgery in somebody who has a tumor involving that area. You can see where it says tumor. That's the tumor. And the right optic nerve, that RTON, right optic nerve, is coming in. The left optic nerve you can see nicely there. The right optic nerve you can see just a little part of it right there. But the optic chiasm is sort of big, it's very full and stretched out. And so it doesn't look like it does in that MRI or in the cadaver. It can be distorted. So with all of that, the question is, can I safely remove this tumor that's in the brain? Well, in order to know that, I need to know where everything is, and I've got to create a corridor or approach that allow me to take that tumor out with the minimal damage to surrounding structures. So that's called Wernicke's area, this area right there, which is an area that's involved. Does anybody know what Wernicke's area is involved with? Speech, exactly. I don't know how many of you watch politics. You know our Senator John Fetterman, who had a stroke. Have any of you ever heard him speak? He has. People say it's an auditory processing disorder. It's not an auditory processing disorder. It's what's called an aphasia, difficulty speaking and understanding speech. When you listen to him, he is a classic example of Wernicke's aphasia. He says he substitutes words, he says words, they don't come out right, and he has trouble understanding when people speak to him, which is part of Wernicke's aphasia. But the other part is an inability to speak properly, which is why his speech sounds so jumbled at times. And he has to have an iPad or tablet to allow him to see the written word, which he can still understand, but he can't as well understand the spoken word. So that's Wernicke's area, which is on the left side of the brain. By the way, an MRI scan, the convention, weirdly, is that left side of the brain is on the right side as you look at it, and the right side of the brain is on the left. So it's as if you're looking at it backwards. But that's the convention, and that's what we've gotten used to. So that's a left-sided or dominant hemisphere Wernicke's area. we've got this blue area, which is, anybody know what that might be? It's in the occipital lobe in the back part of the brain, and it's right up against the right up against the inner part of the brain, where the two halves of the brain come together. This is that calcarine cortex. This is the visual area of the brain. So we've got those two areas that I've got to avoid, and so I chose a corridor right between them, and you can get into and take out that tumor. And I was able to take that out completely with minimal injury to those structures. So I'm just going to walk you real quickly through sort of a typical, what we call craniotomy, or removal of, or exposure of removal of a bone, a part of the skull, to access a part of the brain. And this is a typical. This is a patient whose head is fixed in this head holder. It's got 3 pins that go like this, and they go into the outer table of the skull. This is done after they're asleep, obviously. We put that in, and it holds their head in place and very still. And then we've mapped out with a marker here where we're going to make our incision. That this straight one here, just in front of the ear, that one, that's our representation of what's called the zygomatic arch. If you feel right here in front of your ear, you'll feel that bone right there, and that's that zygomatic arch. And on the skull, that's what it is right there. And all this stuff here, all these lines, that's what's called the temporalis muscle. If you hold your fingers here in your temples and you bite down, you can feel your temporalis muscle move. It kind of bulges out when you do that. So here we go. We're going to make an incision there. We're going to reflect the scalp down toward the zygomatic arch. So we're sort of peeling it down. And now we're looking at the temporalis muscle, or the fascia overlying the temporalis muscle, that sort of a tendon kind of stuff. Now we've scraped the temporalis muscle off of the skull. So this is the skull here, and that deep dark red thing is the temporalis muscle. And then what we do is we make a couple of holes. In this case, we did 3. You can see them there. And then we have basically a saw that has a little foot plate, little tiny foot plate, much smaller than this, and it's got a drill that is perpendicular to the foot plate. And that drill spins round and round and round very fast, and has cutting edges on it. And so what we do is we slip the foot plate under the hole, and then we push it. And as we do so, that drill bit that's up against that foot plate will spin and will saw the bone between those 3 holes. Once we take that off, we're looking now at the dura. This is the covering of the brain, right? The thick fibers covering of the brain. And then if we take off or open up the dura, now we're finally looking at the brain itself. So that's the sequence of what we do to get access to the brain. And once we're there, we do a variety of things. We can take out tumors and so on, fix aneurysms and so on and so forth, a whole bunch of it. This is a video. Unfortunate young man who was in Lebanon several years ago near the farmer's market at 2 a.m. Not sure what he was doing out there at 2 a.m., but somebody approached him and shot him. And the bullet wound went in here by his eye and crossed over and it came out just in front of his ear on the opposite side. So the paramedics found him, and one of the things that they do is they'll try and establish an airway, right? Make sure that you can get oxygen into your breathing. And in order to do that, they stuck what's called a nasal trumpet in his nose. And the nasal trumpet, you'll see in a second, is bright green. It's like a lime green color. And it's about a ½ inch in diameter. And they put that up the nose, and it's supposed to go back into the back part of your nose where it meets your throat and allow that, sort of open up the airway so that air can get back in and out as you breathe. Well, that gunshot wound, unfortunately, had caused a lot of bony damage on top of not in the eyeball itself, but the bone above the eye where the frontal lobe is sitting. And so instead of going up in the nose and back, went straight up through all the cracks in the bone and ended up in his temporal lobe on the opposite side. So you're going to see me expose that over on this side is the nasal trumpet, which you see right here coming through. So this is the temporal lobe, kind of swollen. It's a little bit full. These are what are called cottonoid patties, little strips of cotton. And I'm just pulling the temporal lobe back from the bone in which it sits. And right there, this green thing is the nasal trumpet, that thing that wasn't supposed to be there. And so what I'm going to do is have the anesthesiologist pull it out from the nose while I'm so you want to go ahead and pull it out now when you're ready? You have to advance it. So we'll just have to follow the video from going in. So this is a section over here on this side, and I have in my left hand is what are called bipolar forceps. These are little cauteries that are forceps, like tweezers almost. And so now I'm just pulling temporal lobe back. She's now going to pull that out through his nose, and it's going to come out from the head. A little bit of ooze, venous ooze there, but pretty dry afterward. I had to kind of clean up the devitalized brain, the brain that's obviously damaged. And that's the nasal trumpet right there. A little bit of brain in the tip there.
Brain. Right done.
This, you've heard, how many people have heard of aneurysms, brain aneurysms? Also called Barry aneurysms, yeah. So most of you have. These are weaknesses in the side of an artery that allow a bulge in the side of the artery that comes off. And you can see that here. This is the big ball thing structure here is the aneurysm there. And underneath it is the artery from which it arose. So it's a weakness in the wall, and it just pooches out like that, much like a kind of an inner tube when it gets a weakness in the wall. And what we do for that in many cases is to clip the aneurysm. And so here is a video of not me, but somebody else clipping an aneurysm. This over here, this little silver thing, is an aneurysm clip, and it's spring-loaded so that it's typically shut unless you force it open. And this little gold part right down here is the clip applier, a long instrument. And when we squeeze the clip applier, the aneurysm clip opens up, the jaws open up. We then nestle the aneurysm clip on either side of that aneurysm as close to the parent artery as we can, what's called the neck of the aneurysm, and then we let go of our squeezing, and the jaws come together and pinch off the aneurysm. And there are a bunch of different aneurysm clips. There are curved ones, straight ones, what's called bayoneted, where they kind of go like this, all different varieties. We have to select which one we want. And then once we're done, we take the clip applier off, and we look around the aneurysm to make sure that the clip has gone all the way across the neck of the aneurysm, where we don't want to leave part of it still there. And also to make sure that the clip hasn't inadvertently incorporated a little arteries that are coming off of the parent vessel. And if we were to accidentally include those in there, we could cause a stroke. So if we see one of these little arteries in the clip, we may have to adjust the clip to make sure that we get that artery out of the clip jaws. So that's how you clip an aneurysm. There also are things that we do with endoscopy. We actually have little scopes that we can put inside the brain, which is really cool. Looks like a Jacques Cousteau adventure. The scope goes down into the fluid-filled pockets called ventricles of the brain. These are like little lakes of fluid inside the brain. And in this case, what we're doing with is what's called an endoscopic third ventriculostomy, or ETV for short. We make a little hole in the bottom of the ventricle. So here is, there we go. So we're looking now at the bottom of one of the ventricles, and that little sort of grayish area is a very thin area at the bottom. And what we want to do is we want to put a hole in that. So we take a little instrument there, and we push in that area. Rotate it around a little bit. There's many ways to do this, but you kind of push on there until it pops through, which it will in just a second. And when it pops through and he removes it, I want you to see how the fluid now is released, and it kind of
You can see it coming out of the hole there. See all the particles moving around. There's a jet of fluid coming out there as we created that hole. So lots of interesting things that we can do in neurosurgery. So that's the end of my slideshow. Anybody have any questions while I'm putting my gloves on here?
Is there a possibility that they
Yeah, good question. So the question was, is there a possibility the aneurysm might burst while we're operating on it? Yes, and it's usually quite a show. It's not something we like to have happen, and we have temporary clips where we can actually clip the artery on both sides of the aneurysm. So we put a temporary clip here and a temporary clip there, and that shuts off the blood supply and makes the aneurysm stop bleeding. Usually that's a pretty hairy circumstance, actually, because a lot of times that aneurysm, when it breaks, there's a jet of blood that just literally leaps out of the head and is pulsating away. So you have to clip, stop the inflow into the aneurysm, and then you can look at the aneurysm, clip it, take your temporary clips off. So that's typically the way that we do it. Or sometimes if it's just a smaller hole, we'll take one of those little cotton pads, put it right over the hole with the suction, and then take the clip and then put it and clip the aneurysm that way while we're sort of putting pressure on the hole where it ruptured. But yeah, it not fun when that happens. It's quite an exciting ordeal, and not in a good way. All right, so let's see if I can get this out. So as I take this out, I just want to remind people, this is somebody who donated their body to science. I don't know if this was a man or a woman, but it's somebody's husband or wife, somebody's father, somebody's daughter. They had a life. They donated it to science so that we can be educated. So treat it with respect. Okay? This is somebody who let us learn from examination of their body. So when we look at this, looks very much like the pictures, doesn't it? So we have the cerebral hemispheres here that are covered by a little bit of this is the arachnoid. This is not the dura, but this is the arachnoid. And if I turn this around, you can see the arachnoid covering these sulci here. And if I peel it away, you can see better the sulci and the gyri. The gyri are the things that are sticking up. The sulci are the little valleys between them. These are the cerebral hemispheres, the right and the left side. And then the frontal lobe is here. The parietal lobe is back here. Here's that motor strip, the sensory strip here. So this is the parietal lobe, and the occipital lobe back here. The cerebellum, which has a very distinctly different look to it. These are called folia. These little, you can see how they're very, very small and discrete little, they look like the gyri, except that they're much, much thinner and smaller. But that's the cerebellum. And then if you turn it over, here's the brainstem here. This is the pons. This is the medulla. And this is the medulla in cross-section here as it's been cut across. You also can see, by the way, the arteries and the veins. So you can see a little artery here. You can see the two carotid arteries coming up and the basilar artery right here cut off. And anybody know what the circle of Willis is? Have you been taught that? No? Okay. Circle of Willis is kind of a circle of arteries that joins the carotid arteries and the vertebral or the basilar arteries so that it kind of blood can flow around in a circle and get to all different parts of the brain. So temporal lobes are here. They kind of been beat up a little bit in the removal. This is just trauma from removing the brain, not from anything that happened in life. Right here on the surface of the brain, you hopefully can see that there, that little white strip there. That's actually the olfactory nerve. Everybody okay?
Yeah, people want to see, so you're all right staying as long as you're not in front of people.
Yeah, again, if you feel warm, feel nauseated, sit down. I've had two people in the past who actually fainted. Both of them guys. So guys, okay, the weaker sex. But this is the olfactory nerve, which is coming from your nose up to the base of the brain, right under the frontal lobes, and that's what that is. So I'm going to just put this down here. and I'm going to cut it. So, by the way, before I cut it, you can see if I take the two hemispheres and I sort of stretch them apart, you can now see between the two halves of the brain. I've obviously not cut it, but if you look down, and unfortunately I probably can't see it very well, but right at the bottom there, you can just make out the corpus callosum.
So they can see it.
Ah,
Yeah.
thanks.
Sure.
So you can just make out the corpus callosum that's attaching those two hemispheres together in the depths of this thing. So I'm going to cut, first of all, down the middle. And there looks just like the, right, looks just like the pictures I showed you on the slides. So you can see the corpus callosum running from front to back here. You can make out the brainstem with the pons. This is called the belly of the pons, understandably so, kind of like my belly, kind of sticks out there. And then the medulla down below, and the midbrain is up above. These little pockets in here are the ventricles. During life, these are filled with basically water called cerebrospinal fluid. Anybody hear the term spinal tap or lumbar puncture? When we put a needle in the back and we're getting that cerebrospinal fluid, looks like water. And that actually starts in here in these ventricles, and then it sort of runs around from one ventricle to another, sort of like going from room to room. And eventually it comes out through these pathways to the outside of the brain and around the spinal cord as well. So when we do a spinal tap, that's the same fluid that's inside the brain and around the outside of the brain and spinal cord. Cerebellum here, you can see, and it's connected sturdily to the brainstem here by these peduncles, which again, the sort of tree trunk connections that connect the cerebellum to the brain stem. That's about all I want to show you from there. So what I'm going to do is, if you want to come up and gather around the table, you can watch me cut this, those of you who'd like to do that.
Taller, maybe front row.
It kind of smells a little bit because it's in So now if you look at this, this is half the brain, right? The other half would be here. Now you can really see those cavities here that are called ventricles. And this little stuff right here, see this little stuff right here? Kind of looks like a little, I don't know, looks like a little broccoli or something there. That's called choroid plexus, and that's the stuff that makes the cerebrospinal fluid. So this is actually taking blood. The choroid plexus is a bunch of blood vessels, and it secretes water from the blood. It extracts it from the blood and makes that clear fluid that we call cerebrospinal fluid. For those of you who've had done this or studied this, this little gray bump right here is called the caudate nucleus. Anybody hear these terms?
That one, not yet.
Not yet. Okay. So that's the caudate nucleus. And if we go down a little bit further, let's see if I go. So if we go down further and look at this, the caudate nucleus is here, and there's another nucleus that you probably will learn about called the putamen. That's this little guy right here, and the globus pallidus is sitting down here. These guys are collectively called the basal ganglia. Does anybody ever hear of Parkinson's disease?
Yeah.
People have that tremor and the shuffling gait and so on. That's a problem with the basal ganglia, particularly with the what's called the substantia nigra, which we don't see here. But its connections to all of these things are the things that coordinate your motor movements. And when they're damaged, for example, with Parkinson's, you don't have normal motor movements. You're not weak, but the coordination of your movements is impaired, and you have this tremor and so on. The cerebellum also controls your movements, particularly with coordination of your movements. So damage to the cerebellum causes a problem with your coordination of movements, but the cerebellum, when you damage it, unlike Parkinson's, when you damage the basal ganglia, when you damage the cerebellum, you basically get an inability to reach out and touch things. If you try and, whereas in Parkinson's disease, if you're at rest, you're not moving, you got this tremor, and then you try and walk, and it's kind of like this shuffling walk, and you know, doing this kind of thing. And when you damage the cerebellum, it's when you reach for things. So if I go to reach for that, what will happen is my arm will go like this, and it'll get worse the closer I get to that. If you ask people to touch my finger and touch your nose, they reach out and they like that, or they like that with their nose. You ever see police do their, I'm sure you've seen on TV, police do, hopefully not in person, do the drunk testing, and they have you walk and so on and so forth. They're testing your cerebellum, which is impaired with alcohol or by alcohol. So I'm going to take this cerebellum. You can see how the cerebellum, again, is connected to the brain stem here, and I'm just going to take and separate the cerebellum off the brain stem. If I get through these peduncles, it will, there we go. So the cerebellum is connected to the brainstem by these peduncles. And the lighter gray area, that sort of looks like whitish, that's white matter, which are those of you who, again, are studying psychology, those are the axons, the little processes that go quite a ways, and are covered in a substance called, anybody know what they're covered with? Myelin. Very good, very good. And myelin is fatty, and so it's white. And that's why these are lighter in color than the gray matter, which is darker here. So the gray here, the folia of the cerebellum, which has the cell bodies, is more gray, and then as the axons lead and go down toward the brain stem, you can see they're whiter, I should say, lighter gray. Where's Mr. Steelman?
I'm right here.
Good job. This is the best crew ever
They're engaged,
in terms of knowing stuff.
No, credit to you. Thanks.
So, let's see. So I'm going to make some slices here. There's probably not a lot else to show you up here, but I'll make the slices anyway.
It looks like a mushroom.
Looks like a what?
A mushroom.
Yeah, it does kind of look like a mushroom. You'll never look at mushrooms the same way again.
I don't like mushrooms, so it's fine.
Oh, there you go. So there's that, from top to bottom, as we slice it, you can see how as you come down, you can see different things in different sections. I'm going to come down a little bit further into the temporal lobe here, and hopefully I'll be able to show you the hippocampus. What's the hippocampus do? Anybody know? Memory, exactly. Memory, and also is involved in what we call the limbic system, which is responsible for emotion. So, we'll see. So here's the hippocampus right here, that little structure right there, and it looks in 3 dimensions kind of like a little seahorse. That's what people try and make you believe, but in cross section, it kind of just is a little blob there. And
Wait, how'd you know?
4 years medical school, 7 years in neurosurgery residency, 2 years in pediatric neurosurgical fellowship, and 22 years as a neurosurgeon. That's right. So I'm going to cut this one coronally. How much time do we have? We good?
15 minutes.
15, okay. Good, we're getting near the end, pretty much on time.
Yeah, you can.
So now you can see some things look fairly similar, and I'll point them out to you in a second. But we're now cutting these coronally, sort of as if we were cutting from your face back. And okay, so yeah.
Is it a similar texture before it's in the
Yeah, great question. It's softer. This is much harder, firmer, more rubbery than it is in real life. Yeah, that's a great question. It's not this firm in real life.
Is that from the preservative or just from not being in somebody's body?
From the preservative, yeah. When you take it out, it's really pretty soft. So now we can see, we can make out in coronal section, again, these ventricles here, when we're cutting them this way, right? We see the ventricle there, and you're not seeing a whole ventricle. The ventricle is kind of like a C. A lot of the structures in the brain are sort of C-shaped, and they come from the front over the top, and then they come down, and they go into the temporal lobes. So it's kind of a C. So you can imagine as you slice these, you're going to see different parts of those structures, and they're going to look differently depending on where you cut them. So here's the front part of the ventricle. It came up like this. In fact, here's the top, the roof of it. So that was here, right? So when we cut that off, there's the roof, and then it comes around and down there, and then it comes down there. That's the end of the temporal horn, and this is what remains of where it goes into the temporal lobe. This is the temporal lobe here. This is the frontal lobe here. And again, hippocampus right there. I'm going to try and find it. Here's the hippocampus right here. I'm sorry, no, that's not the hippocampus. This is hippocampus here, down here. So it sits right below the ventricle in the temporal lobe. And actually, it sits right below this structure here, which is white matter, right? This is much lighter. This is the optic tract. So when we're removing the hippocampus, for example, for somebody with epilepsy, we got to be sure that we don't go up too high because we'll interfere with their vision. So we got to know where we are, again, at all times. Again, cerebellum here, part of the hippocampus here, just inside of the temporal horn of the ventricle. Again, this is the choroid plexus, this little bumpy stuff here that makes the cerebrospinal fluid. And I don't see anything wrong with this person's brain. I'm not a neuropathologist, but I don't see anything that would suggest, a hemorrhage or a stroke or anything like that. I don't know what this person died from. We don't have any information about who this person was or why they died. So I have yet to find anything real significant in any of the brains that I've cut for class.
Doctor, does anything tell you as far as atrophy, like the rough age of the brain?
Yeah, great question. So when we're little, our brains are rather plump, and your brains are good. My brain actually is probably a little shriveled compared to yours. As we get older, the gyri, right, this cortex, tends to shrivel up a little bit. Interestingly, I had an MRI scan when I was much younger. I was only probably in my early 30s, and I had an MRI scan just for fun, and doesn't hurt. But what's interesting was that my cerebellum is actually a little atrophied, and sometimes people who drink a lot that's one of the causes that can cause cerebellar atrophy. Now, I don't drink hardly at all and never really have. I know. Everybody says, yeah, sure. But I really don't. And I don't know why my cerebellum was a little atrophic, but it did lead to some razzing from my colleagues. Wonder how I could be a neurosurgeon with a shriveled up cerebellum. It wasn't that bad. It was, but a little atrophic. But yes, great question. It does. Your brain does shrink a little bit as you get older. Any other questions?
Yeah. Could you just move the bucket a little bit?
Oh,
to the
I'm
left?
sorry.
Yeah, that's perfect.
There you
Thank
go. I should have thought of that earlier.
Thank you. When you're actually performing surgery, is it hard to figure out what you're actually looking at?
Yes, and it takes a while to try and figure out. As I said, putting it all together, and there are no roadmaps. Once you get under the surface of the brain and you're going into the white matter. By the way, this is the white matter, which has all those myelinated axons, the myelin around them, and the gray matter is where the cell bodies are. So I forgot to point that out. But yeah, the white matter is very nicely seen in these brain sections. But once you get inside, and particularly when you're inside the white matter, there's no signpost to tell you where to go. And I will tell you that when I first started, we didn't have any machinery or technology to help us know where we were in the brain. It was all done by this knowledge that you had of, okay, I should be coming up on such and such, and I'm just because I know what the brain looks like and all the anatomy, I know that this is going to be over here and this is going to be over there. But there were times when you really are very anxious because you're not sure if you're exactly where you think you are, or you may be off slightly. And there's no signpost to tell you, oh, hey, here's the hippocampus. On the outside, it's much easier because you can see the bumps and the gyri and the sulci and so on. Now we have computer-aided guidance where we actually have infrared cameras that shine on the patient's head, and before the surgery we get an MRI scan, and we insert that MRI scan data into this computer, and the computer makes this whole map of the brain, and the two infrared cameras are looking at the head, and you register the head, and basically marry your external head, your real head, with the MRI, so that now the computer can tell where you are at any point in time, because you're holding an instrument that the computer, those infrared cameras recognize. And so what will happen is you get close to the brain and you go through the brain, you'll see the MRI scan, and the images will change as you move. So you'll get different slices as you move deeper in the brain, and a little crosshair will go, you are here. So you can actually, in real time, know where you are. And that's been a godsend for neurosurgeons, because we've been able to now much more accurately figure out where we are at every point during the operation. Yeah.
I have a question. Is it true that the brain stays active for a few seconds after getting your head cut off?
We don't know that because nobody's told us. Probably there are a couple of seconds where you do that. Whether you are conscious for a period of time before the pain from your neck gets to your brain and your brain processes it, or do you go unconscious before that? Probably don't know. It's probably on the order of seconds or less that you would be conscious, because as soon as you cut through the carotid and the vertebral arteries, the four arteries that feed the brain in the neck, of course your blood supply stops, and you usually go unconscious pretty immediately.
I just want to say I was only asking because in history we're learning about the witch trials, and people got their head cut off, and they said they were screaming for for 1 second or something.
Yeah, the problem is that there's a lot of reflexes that can occur. So they may have opened their mouth like that, and people sort of maybe interpret that to be a conscious effort. It may just be a reflex, and not even due to any brain function. So, but the bottom line is we don't know, because nobody can tell us. It's kind of like what happens after you die. We don't, honestly, we don't know.
Right. Well, I mean, some people do, their heart does stop and they bring them back.
That's a good question.
Correct. And people have these interesting out-of-body experiences. I'm sure you've heard about out-of-body experiences. There was a journal article several years ago in one of our neurosurgical journals. They found an area of the temporal lobe which, when they stimulated it in a patient who was awake, because sometimes we do awake operations on people, we numb up the scalp and so on so they don't feel any pain, but then we stimulate parts of the brain looking for parts that might cause epilepsy and so on. Anyway, they found an area of the temporal lobe which, when stimulated, created an out-of-body experience. Patients felt like they were like looking at themselves from outside when that part of the brain was stimulated. Yeah, so it calls into question these near-death experiences where people said, yeah, I was looking down at the top at everybody in the room doing all this stuff, and I was floating above and so on. It may be that that part of the temporal lobe was activated as their brain was shutting down and was causing that sensation. Again, we don't know. Any other questions?
I know it's probably based on situation, but what's the most difficult procedure that you have to perform?
There are a few. One of them is a particular tumor type called a craniopharyngioma, which sits just above the pituitary gland and around that optic chiasm. When I showed that picture of the optic chiasm and that tumor that was pushing it up and stretching it, that's the area where the craniopharyngioma rises. And it projects up into the hypothalamus. And there's a lot of stuff around it that's very important. And when you take it out, the patients are at risk, more than average risk neurosurgically for having problems, one of which is a condition called abulia, where they wake up and they have no motivation, no drive, and they kind of look like sloths. They move very slowly, and if you ask them a question, it takes several seconds for them to answer a yes or no question. And I had a young man, teenager, who actually did that after surgery, and from which he did not ever recover. You would ask him a question, and he would just kind of, yeah. It's one of the, in a negative way, one of the most memorable points of my career.
What's your prevalence?
The longest surgery I've done has been about 20 hours. And actually on that young lady, as a young adult, we actually did it twice, each of them about 20 hours. It was on her neck trying to take out a tumor that was wrapping around her spinal cord. And so the first 20 hours, we went around her brachial plexus, the nerves that were there, freed up the tumor, took bone out, so on, removed the tumor from the front, and fused her. The orthopedist fused her. And then a few weeks later, we brought her back, and then we went from the back, and another 20-hour operation. That was Herculean. But that's the longest I've done, is about 20 hours.
Have you ever been in an operation and where your guy just falls out?
Not anybody who's involved in the surgery, but I have had visitors who've been in the operating room with me. I had a therapist one time who wanted to watch surgery, and I was under the microscope for a spinal cord tumor, and I was on one side operating, and my faculty members, when I was a resident, was on the other side, and we're operating, and all of a sudden I feel this on my back, and I mean literally I'm under the microscope operating on the spinal cord, and this guy bumps into me, and I turned around and I said, "Hey, what the hell are you?" Oh, and he fell back, boom, on the floor of the operating room, and sort of jerked a few times, and then was still, and yeah, he jerked actually because of low blood flow to his brain, because he passed out. And so yeah, he jerked, and then we had somebody, cart him off basically, so we could keep on operating.
You said it's called a peduncle?
Peduncle, yeah, Peduncle.
Interesting.
Yeah, there's a cerebral peduncle, which is the connections from the cortex, the motor connections from the cortex down to the brainstem, and then there's the cerebellar peduncles, which connect the cerebellum to the brainstem.
Who came up with that name?
I have no idea. I'm sure it's Latin for something.
Just Dr. Time, just the time heads up, there's about 3 minutes till there's going to be people coming in here.
Yeah.
So maybe if they were going to glove up and access the brain,
Yeah.
I don't want to rush you.
Yeah, if you want to do that, you're welcome.
I'm going to ask people that have lunch next period, you've got a little more time. If you can sort of hang back, especially if you've been up front, some people haven't gotten a closer look. If you have to be somewhere 7th period,
How would you fix trauma to the brain? How would you proceed?
You can't put brain back.
Yeah. Give me some
Once trauma or damage is done, it's done.
You just work with it.
Yeah, you have to.
I dare you. That was just needed. I will pay you.
Hey guys, can you make sure this is
Look at City Boy.
Are you just talking to me?
I'll take it. Oh, fine. I'm going to pick this up and take a photo. It's so nasty.